So my name is Kush Desai. I'm a associate dean and a professor, or sorry, assistant professor at the Medical College of Georgia. Also over the one of the regions for the CDC grant that we have in the state of Georgia. Just so we can get to know each other. I know a lot of you guys have already started doing this, but you can put your name, your position, and your organization, as well as your contact information in the chat. We can go and do a next slide, please. So this is the first time we've actually used this TeleECHO platform. It's a really at first it seemed a little bit confusing, but actually it's a really nice platform that the ECHO folks have created. You got it. Yeah, so it makes it really easy to once you get used to it a little bit, it's actually very easy to register for these sessions. And it's actually really nice because you can register for other sessions as well as access other information. So ECHO is a national, actually international organization and an international platform, and there's all kinds of topics ranging from everything. It started initially with treatment of Hep C, but every single topic you can think of, from stroke to heart failure, to cancer, to infectious diseases, are on this platform. And so anybody that registered for this can actually access any of those lectures and that content for free. And you can register for future ECHOs for live sessions as well. And so, and it's free of charge for anybody that does this. And it's really a nice thing and a nice way to learn. And so I myself registered for this, and I'm going to get all my residents to do the same, because this is a really great way and a great educational platform. But so as everybody is on the call, you guys are welcome. If you have already registered through TeleECHO, that's great. If you haven't, you guys are welcome to do the same. You can access the same session, the same Zoom link through that platform itself. And if you guys have any issues with that, please email Brenda or myself, and we can help walk you through that. You can do a next slide, please. And also you can access on your phone too, so you can do phone or desktop. All right, so today's agenda, just as all our ECHO sessions have gone so far, we always do introduction. Then we have an expert presenter who gives a lecture. We have some time for questions. Then we go into a case presenter, more time for questions, and then we go into the conclusions. Next slide, please. So the motto for Project ECHO is moving knowledge instead of people. And it stands for community for extension for community health outcomes. Next slide, please. Just a couple of reminders: these sessions are recorded. We do we expect that everybody's consenting to recording. We also collect data for quality improvement purposes. And please don't mention any PHI. Next slide, please. Next slide, please. Just general Zoom reminders. Just remember to mute yourself when you're not talking and unmute yourself when you are talking. We are a very interactive type of platform and an interactive type of meeting, so we encourage questions. So please do ask questions. Put them in the chat box. Ask them using your mic and in your phone, or you can raise your hand and we'll call on you that way as well. Next slide, please. This is just a disclosure for Dr. Jones, who's going to be our first speaker, so you guys can take a look at that there. Next slide, please. So our first presenter is Dr. Whitney Jones. He's a gastroenterologist and a former clinical professor of medicine for the University of Louisville. He's a founding member and currently serves as the chair of the Kentucky Colon Cancer Screening and Prevention Program Advisory Committee, serving the un and underinsured. In 2023, in 2003, he founded and remains active in the Colon Cancer Prevention Project, a leading CRC information and advocacy organization focused on innovative acceleration of evidence-based screening, including emerging biotech and logistics. The major focus of the project is advocacy around pragmatic state-based laws which lower barriers to access evidence-based CRC screening. We've had Dr. Jones on our ECHO series before, and I've met him many times at many conferences throughout the nation. And so he's becoming a good friend and a mentor and a very strong advocate for CRC screening. So we're really fortunate to have him today to talk to us about blood-based CRC screening. Dr. Jones, if you can go ahead and share your screen, you can go on with the presentation.
Great. Thank you so much for that kind piece. Can you guys see that okay? Excellent. Yeah. I gave a whole lecture to the state of Montana and my voice and slides didn't come over. So thanks for the feedback. So today we're going to talk about blood-based screening. And again, what I really want to do is sort of give you guys a high-level overview. I'm not a molecular biologist or, research scientist, but I know at the end of the day, out in the trenches, what you guys need to have is some broad views and approaches to these new technologies that are coming in. So I'm going to try to lay that out for you guys today. And again, I appreciate the great invite. Hold on. Just want to get this bar out of my face here. All right. Here's my disclosures. And I've got sort of a slow response there. So when we talk about blood-based screening, we're necessarily talking about DNA. And again, DNA has sort of moved us away from our structural issues, colonoscopy. But at the basis bottom here is really the Human Genome Project, 3.2 billion base pairs sequenced dramatically. This is the foundation for genetics and genomics. But right alongside of that, over here on the upper left, is the cost of sequencing, right? The cost of sequencing follows a Moore's law type of piece where what used to be millions of dollars is now, occurring in terms of whole genome sequencing for under 1,000. So as drivers of cost, the major drivers in all genomics is going down. And I mean, going down dramatically to where it's going to become retail. On the right, though, is a new phenomenon that we've all been hearing about more too recently is artificial intelligence. Machine learning is part of that, and deep learning is more of a neural network. But machine learning, it's the same as anything else, garbage in, garbage out. It's set up by people, but the machines are then trained to solve problems given certain parameters. And when I look at the cost of sequencing as well as improvements in sequencing and machine learning, I am thought about other areas where we have real huge synergies. When you put CAT scans, when you put x-rays and computers together, we got CAT scans. When you had radio and telephones combined, we had cell phones. And when you had Google and algorithms and the internet put together, we have search engines. These are things we will never go back from. And likewise, I think the genomic and molecular revolution is something that we're squarely in today. And when we talk about DNA, I got news for everybody on this call. If you haven't trained yourself, you probably didn't get trained in medical school. And so the way you're going to get better trained is by using resources such as the internet and YouTube and other articles, because this is not your parents' DNA anymore, because we just learned about, ACTG, but and that's still super important. But now we're going to be talking about things in colorectal cancer, about germline mutations, somatic mutations, epigenome, which is huge. The epigenome is really the regulator for your genome. Only about 3 to 5% of your DNA even makes any sense in terms of protein. So how do we know what to turn on and what to turn off? Within that are methylation, acetylation, phosphorylation. And as I'll probably say once or twice, the entire cellular process is eventually going to get hacked. And that's going to become part of blood-based screening, not only for colorectal, but for cancers broadly and likely other types. But colorectal and luminal stuff is really important because we don't just have access to DNA through the blood, we actually have it through the lumen of the gut. But what I want to caution everyone about is, the lack of catching up with technology. Oncology has done a great job of integrating somatic mutations into treatments. They're like the experts right now. But germline testing for Lynch syndrome and other things have been around for 30 years, and we still have less than 5% participation. So if you guys out in the primary care world don't close the gap between the technology and your understanding of it and how to use it, it's going to be sitting on the shelf. So this is a fascinating thing in colorectal cancer. And this is a picture of the colon here. And again, it's very interesting because colorectal, we have two analytes we can actually sample. We can sample analytes of stool or the effluent from stool after we've gotten it out. And that can help us identify pre-malignant markers as well as malignancy markers, physical features such as bleeding, and then also DNA methylation, epigenomic patterns, somatic mutations, etc. And again, right now we use it for the GI tract and the colon, but there was a time we were worried about the entire GI tract causing soiling, if you will, of the sampling of the colon effluent, but that's felt not to be the case. When we look at blood in the colon, we're primarily looking at malignancy. And these are small cell-free DNA fragments, but down the road, mRNA, proteins, we can see metastatic cancer cells in the blood, but the vast majority of these are going to be malignant markers because by definition, cancer does not penetrate into the submucosa at the bottom. Oops, sorry about that. It stays, benign diseases like polyps stay localized to the mucosa and don't bury down. So only when malignancy has gotten into the submucosa do we get access to the vascular system. And so that's like take home number one. Blood-based testing isn't going to give us a ton in terms of pre-malignant lesions. So this is really how it looks like. So we know when cancer develops, it usually starts as one cell and clonally increases. As that gets larger, and particularly as it invades into the wall, DNA shedding of small fragments occurs. And these are not your whole genomes or even chromosomes. These are small fragments of DNA, 50 to a couple of hundred base pairs long, have a very short half-life. And so again, shedding goes on sometime after cancer onset. But again, like anything else, you're not going to find huge amounts of cancer signal if there's only one or two cells. So you have to get a detectable window and a certain amount that can be detected in the blood. And really, it's that interval between the cancer signal in the blood being detectable prior to that clinical diagnosis when blood-based screening is really important, and we can have this pre-detectable clinical window. Shedding, can occur in a little bit longer, but again, over here, we're not really detecting precancerous lesions. We're really looking at cancer. And I will tell you, down the road, might we detect it? We might down the road. We're not there yet, but that's everyone's goal, is that we can detect adenoma markers and advanced adenoma markers in there, but we are not there today. Now, here's the other things we've learned a lot. A couple of things. Number one, most people at risk for colon cancer are not in doctors' offices frequently, particularly the younger folks. Our healthcare system has been dramatically disrupted. Neither stool nor blood require a visit in person. And what we know is we're not really using our databases to do that. But colonoscopy is rapidly becoming a two-step process outside of people with elevated risk. And it's important for those folks to know that there are different parameters. And again, the best test is the one that gets done, but blood tests and stool tests are going to, compared to colonoscopy, have lower sensitivity for both polyps and for colorectal cancer. And again, lowering prevention compared to the, I won't say the gold standard, but to a classic structural exam. So the two-step is really laid out here. We know the issues with FIT. For you guys who are in community health centers, you understand it's tough to get FIT tests done, returned, resulted. Colonoscopy with, colon cancer screening with stool testing and Cologuard has some significant advantages, I think, in terms of being less frequent and having inbred navigation in that. But again, we still have these same issues. Where blood has a very potential significant advantages, all these steps you have to go through for stool in step one, most of these are eliminated with blood, because when you draw the blood, you have collected the specimen and it's off to the lab. Okay, so when that comes back and gets resulted, again, we still have all the problems we're having with step two, which is if it's positive, we've got to get that completion colonoscopy performed in a timely fashion. And even Exact Sciences, with their incredible navigation program, is only to get about 71% of people across the finish line. And I think that's best case scenario. Using FIT, I mean, I know Kaiser Permanente gets over 90% of people across the finish line, but they're quite unique. In many community health centers, that's somewhere between 20 and 40, 50% of people getting stool-based testing followed up with an appropriate timely colonoscopy. So again, blood is going to be a two-step process. So we have to solve the two-step process writ large. So let's just roll into a couple of these. And again, I think what we're going to see is that, there are many companies out there. There's three that are sort of on the verge, but I put up the parameters for FIT and stool DNA or Cologuard up here with their variable sensitivities and their performance levels. And what I would say is that when we look at the first one that's FDA approved, which was the EpiProColon, which is based on septin-9 methylation, the sensitivity was 72%, the specificity was 80%, with a relatively high negative predictive value, but not a terribly high positive predictive value. Sensitivities are lower at earlier stages, and that's pretty consistent. I'm not sure why this glitch occurred in stage 3, but generally with all blood-based screening, you're going to find this stage. And that goes along with the bigger the tumor, the more shedding of DNA in there. And it is approved and it's in the market, but it's not covered, and it's not covered by CMS. Shield is sort of next, and that's a Guardant technology. They're using multi-omics, and I think we'll all eventually be in multi-omics, but a lot of it probably be driven by methylation. And the sensitivity is about 83%. And again, that's better than FIT and not as good as Cologuard. So just for comparison, but its specificity is 90%, which is pretty good, but that's still, 10 false positives out of 100 tests. The PPV and NPV aren't available. Sorry about that. And its stage performance is quite good at stage 1, stage 2, and then again, stage 3. And that's probably statistical. And again, I didn't find stage 4 data where I looked. It's not in guidelines yet, but it is available as an LDT, and I understand they're pushing for FDA approval. Right now, I understand it's an every 3-year test, which is important because, again, we're not picking up polyps, unfortunately, and so we lose that preventative component. Freenome is also working on a multi-omics test. As you can see here, the performance and sensitivity and specificity. And again, stage 1 and 2, 94%. So these are all in development. Some of these are going to be in the market, and again, we'll talk about some of the issues around the cost. Because of time, I'm going to skip this. I did include 3 abstracts in the back of this lecture, which will be available in the slide deck. But these are abstracts on stool versus blood broadly. And again, these were performed by Fendrick and also. Many of these came out of the Exact Science as well as the VBID school up at University of Michigan. And these were just broad looks. And again, remember what we're dealing with. These are not built for adenoma detection. They're not built because the adenomas by definition don't access the blood because they're limited to the mucosa. But even with optimal performance of blood tests, life year gains at 1-year intervals with blood tests, are possible if you're doing them every year. But these are, again, right now being proposed potentially for 3 years with a lot of extra colonoscopies because of sensitivity and specificity issues. Even if you have perfect adherence and really high adenoma detection rate, which is not what we have right now, it may be that we don't have as many life years gained and a higher colonoscopy rate with every 3-year versus every 3-year stool testing. And it's really only comparable to annual FIT when we use estimates of highest adenoma detection rate for any non-colonoscopy test. And so again, really not there in terms of what we have right now. And I think the biggest issue at the bottom here is the value-based pricing in order to reach what we have right now. The costs that are going to be on the market of, I think, $900 plus for the Shield test really doesn't get to value pricing unless it's 5 to 8 fold lower. So again, like every biotechnology product, they start off very expensive, and over time with scale, with competition, with improvements in technology, they all get less expensive. So I wouldn't let this initial price tag designate what that's going to look like in 5 years or 10 years. But again, what I want you to know from a blood standpoint is we are absolutely going to be seeing expanded, not just stool options as we see, but we'll see more expanded liquid options. This is coming. Every single genomics country is working on this. I would add in there the consideration about genome sequencing, which I'll talk about in a second. And one of the things we never talk about are hybrid strategies, which are really using blood and or stool along with colonoscopy and using a larger risk matrix. But blood-based screening is going to really impact the entire spectrum of cancer. Universal whole genome testing is being looked at right now at the Mayo Clinic, so you won't have to wonder if your person has Lynch. They will have had a genome already done, or BRCA, or familial hyperlipidemia. And this is important in my world because 49% of minorities and 32% of white individuals don't meet NCCN guidelines for BRCA or Lynch syndrome. So I think we're leaving lots of people out of genetic testing. Also, if you're looking at blood-based screening, you have to understand that we're going to see multi-cancer screening coming along, and this is not competitive with single cancer screening, but it will impact it because you'll still need to work these up. Multi-cancer involves, instead of one organ at a time or just doing one single cancer, what you're going to be looking at is simultaneous capacity to screen for multiple cancers with a single medium like blood that'll be efficient and cost savings. There are multiple companies around the world who are working on this. And so again, as you do your self-education and reading, make sure that you're understanding how this performs and the fact that it will be part of our landscape more than likely. And this is a results from one company. And you can just look up here at the colorectal sensitivity, just picking out one cancer. Again, lower in stage 1, improves with each stage. But again, not too shabby with regards to colorectal as a single cancer alone. So I think we'll be having those discussions, but all of the multi-cancer tests are used to complement, not replace, single cancer screenings. And so as we finish up, because I want to make sure we have time, there are a lot of challenge about currently available technology versus what we have in our hand right now, which is FIT and Cologuard and colonoscopy. And the real question is going to be whether the improvement in the two-step problem of screening for these blood and stool tests, whether the increase in compliance for part 1 of that is going to be made up for by the lack of adenoma detection in stage 2 when people get their completion colonoscopies. That's really where the rubber is going to hit the road. I think in terms of cost, we've always mentioned these are going to come down. We have to have real studies how it's going to work in disparate population. There's a lot of untrust. Giving people your blood and DNA may not be, in fact, something that people want to do, but we shall see. I think we need more research on blended strategies where we're using both analytes as well as structural screenings in different temporal methods. And then finally, I think there's going to be other blood-based strategies as well as a hacking of the cellular process. So in all, I think I'm going to expand blood-based screening to our tagline at the National Cancer Roundtable. Over time, with improvements and more data, I think it will eventually join the ranks of screening, and it will become part of that group where the best test is the one that gets done. Here's my contact information, and I'm going to turn it back to the boss. Kush, coming back to you.
Thank you, Dr. Jones. That was a really interesting presentation and a lot of really cutting edge information that you were able to present. I have several questions, but I'm going to give it up to the audience. Hopefully they have some questions as well. If not, I can ask what things that are on my mind. So is there any questions from the field? Looks like Kyle has a question. And by the way, Kyle, thank you for your recommendation. I think you asked me a few months ago on bringing up this topic. So we appreciate the feedback from Kyle and from others that wanted this topic to be discussed. So Kyle, you can go ahead and ask your question.
So I was curious, how long do you think it'll take before some of the gastroenterologists and general surgeons get behind this? Because, obviously, colonoscopy, that's what a lot of them want to do. So do you see any lack of backing from those different organizations as a potential hindrance
That's a great question. So this is how I begin to answer it. I think that during the COVID epidemic, we had a lot of the soft spots of the underbelly of the healthcare system exposed. And up to the point where we weren't keeping up with screening, there's still a lot of urban areas that have not caught up. So I think gastroenterologists have begun to accept that stool-based screening as a two-step process is real. And you got to understand that's been decades in the making to get them to accept this. I think they're going to be wanting to see more comparative data with existing guideline approved tests before they are fully bought into blood-based screening. It may end up that this is a rescue piece, but again, I think the idea of a rescue screen from someone who won't do a Cologuard or a FIT or a colonoscopy really doesn't make sense. Because if you're not prepared to agree during the first part of the screening, hey, if I have a positive blood test or stool test, I'm going to get my colonoscopy, you're really not participating in a screening piece. So I think doctors will get this. And the real question is, when we're looking at the long-term outcomes, is that balance of getting more of the repleted, so we can all be Kaiser Permanente when we get our blood test, right? We can all get our FIT test back. Is that going to outweigh the lack of prevention through polyp removal and detection, as well as sensitivity at earlier stages? So I think docs will come along, but I can't tell you if it's going to be 3, 5, or 10 years.
Thank you. Is there any other questions for Dr. Jones on this topic? So I'll ask my question, and then we'll see if anybody else has any follow-ups. But so my question would be, so is there a risk so that if people feel really comfortable with a blood-based test that the stool-based test will just completely go away? And if that happens, is there a risk that we're going to be missing some of these adenomas that we really can't?
I think that's the risk, right? I mean, I know that people would rather get a blood test, I think, than play with their poop. That's just the way it is, I think, for most people. However, we're going to lose in prevention unless we can improve the adenoma detection rate, right? You know, in Kentucky, our incidence is down 33% because of polyp removal. Right. And that's 650 people per year not getting it. So we cannot, let go of adenoma detection, particularly advanced adenoma detection and removal, as a cornerstone of colon cancer control. And so I think the real question, I tried to create that in there, if we can, instead of in a community health center where maybe anywhere 20 to 50% of people are getting screened because they don't want to mess with their poop, if we can get that elevated up to 80 or 90% because it's a simple blood test, that may be able to challenge the prevention piece because of more people. But and again, those abstracts I included in the slides go through several of those issues. And again, I recommend reading them. But that is, I think, going to be the question, as well as cost. Cost is going to be huge. It's too expensive at this time. So Dr. Hotz, I see your hand up.
Once again, a very effective presentation. Just before this, the American College of Physicians had a webinar on the controversies of colorectal cancer screening, basically saying, hey, we really are at 50, not 45. And what they said is that we do not have a randomized controlled trial, just modeling studies about the effectiveness of screening from 45 to 50. And, that's what makes the world complicated for those of us in the field, where you have conflicting guidelines. And a lot of these tests being developed from blood, will probably never have a randomized controlled trial to see if the blood test is actually better than another one. How do you see the challenge of taking this and actually placing it into a guideline and need for these kind of randomized trials that some people say is the evidence you need to really, say everybody should have something done?
Yeah. First of all, as a member of the American College of Physicians, our guidelines are wrong. I think what we're seeing is the ability for technology to develop and it's outrunning our capacity to perform these long randomized controlled trials with cancer mortality as an endpoint. So I think what we'll see are these surrogate markers like stage shift, right, or cancer mortality. And I think what we've got to see from a regulatory standpoint is for, our regulators to step up. So many times, just like Exact Sciences, they had a collaborative agreement that they would continue to report data while it was in market and in use. And that real world evidence, contributes to that. So I think the problem isn't that the technology is developing too fast. I think it's that our regulatory framework has not kept up with the times in terms of these changes. And by the way, each time these tests will undergo iterations and improvements in the algorithm that drives them. And imagine having to go through another 10-year process because you improve your algorithm based on biobanked specimens. So I think we've got a big change to make. I'm sorry, I think the ACS is wrong. All of us in the Southeast and across the country are seeing more young colon cancer. But it's a challenge, but I think it's a regulatory process issue, not a biotech issue. And I think, Ignatius, I think you were next on the question.
Yes, I'm sorry, I didn't, I was coming in because I was trying to log in, having difficulty. So I didn't get to hear all your presentation. So mine is not really a question, but I just maybe a request. Is it possible for us to get a PowerPoint of your presentation for those of us who are unlucky to hear you speak?
Yep, that's Kush. I think that's part of the platform, and I've already forwarded those slides to the ECHO team.
That's exactly right. So let us know, but you'll be, if you're on the iECHO platform, you'll get access to Dr. Jones's slides and presentation as well of all the previous slides we've done, previous presentations we've done. But that's a great question. And Dr. Sahar, I think we have a couple minutes before I have to get into the next one, but Leora, if you want to go ahead and ask your question.
Yeah, I'll be quick. Thank you, Whitney, so much. That was fascinating. Not my area of expertise in any way, shape, or form, but I assume that those algorithms are either AI assisted or AI based, correct or no? Yes. And I would love to know, I mean, we see such huge progress with those algorithms. I mean, I've seen papers several years ago about AI assisted, blood tests for colorectal cancer, heard about that for lung and for others. Where do you see that going, and how, I mean, going from 80% to much more than that? So if you can comment on that, that'd be great.
Yeah, well, I'd say the main issue that's the rate limiting step in blood-based screening is the actual amount of DNA, cell-free DNA that can be assessed through a sample, right? That's why with every single blood-based test, you have lower sensitivity for stage 1 than you do for stage 2, 3, or 4. But I do think what we'll see are incremental improvements, but I don't think we're going to ever have a blood test that's 100% sensitive, et cetera. I think we'll always see those stage differences. To me, the biggest challenge in colorectal is the fact that identifying precancerous lesions is part of our strategy. And because by definition, adenomas don't invade below the muscularis into the submucosa where the vessels are, I think we're always going to have a paucity of sampling. So again, maybe part of that combined strategy ends up being, blood and stool, not just blood or structural exam. So I think there's a lot of creative people out there who are going to be studying this. But I think what you'll see are iterative, incremental change, Dr. Sahar, not massive, huge changes unless there's a major breakthrough in some of the basic science around cell-free DNA and blood-based analytes.
Thank you.
Thank you. Yeah, really interesting discussions we've had. So we're going to get started on the next section of this session. This is going to be Dr. Rita James, who's a nurse practitioner at the Edison Medical Center at AAPHC, and she's going to be presenting on Chasing the Triple Crown, Case of the Edison Medical Center. So Dr. James, you can take it away.
Hello, how's everyone doing today?
Great.
So Chasing the Triple Crown at Edison Medical Center. You can move to my next slide. So Edison Medical Center, we are very small. Edison, there's only 2,865 people. But, you know, a wise man said to me, he said, even though we're in the rural area and we have patients who have socioeconomic poverties, that they don't want to die from colon cancer or any other cancer like their counterparts, rich people who live in urban areas. So for us to capture the triple crown, we need 80%. And breast cancer screening, cervical screening, and colorectal screening. Last year, we were at 80% in both breast cancer and cervical cancer screening. At the end of this year, we dropped to 78%. And go to my next slide. And one of the reasons could have been because we did the new guidelines at 45. But we're at 84.2% in breast cancer screening. And we're at, and we've met that, as you see, we met that goal. And for cervical cancer screening, we're at 72%. We need 25 more patients so we can meet the 80%. And then for our colorectal cancer screening, we're at 74.4%. And we need 36 more patients. I'll go to my next slide. And we are one of the smallest clinics within Albany area primary healthcare organization, and we are a large organization. And we're also one of the most rural clinics. And we have some of the patients, lack of education, lack of resources. We really have like poverty in our areas. And I've been posed the question is, how do y'all get such high scores? And what makes the difference is that I feel like we're able to connect with our patients. When a patient trusts you, you know, when we start talking about colon cancer, even mammograms and pap smears, they trust us. They will do those screens. And we give out free clinics. Patients can come in, they can get a free pap smear. We do free colorectal screens. So we have a lot of resources that we're able to provide to our patients. And we have navigation, people who navigate. They call patients in for the screens. We have good staff. We have staff that's been here for a while. And that's one of the biggest difference is that if they, you know, they can come to their provider, they can see their nurse, and they feel comfortable, and they will do some of the screens that we ask them to do. And I can say, like, some of the challenge that we face is because we are in a rural area. We do still have patients who have transportation insecurity. And we are trying to overcome a lot of these challenges. We're not just strictly maybe a Monday through Friday. We will maybe on a Saturday, if that patient doesn't have transportation, they have a family member that's off on a Saturday, they can come in and get a free screen. Go next. And we work hard to get our patients screened by each year. And as I said earlier about the free clinics and the clinic navigators, the population health teams, they go in, they identify all the people that we need to get in. And patients can, you know, if the fit and the pap smear are out of date, we get them back in. Patients get calls. Dr. Hotz, he kind of helped to spear a lot of this. And then also Robbie, he's been very instrumental in helping us to do this push. A lot of people are amazed that even though we're in a rural area, that we're able to get a lot of screens and that we have high scores. At this time, I'll take questions if anybody have any. Thank you.
Thank you for your presentation and congratulations. I mean, y'all's numbers are incredible. You guys are providing very good preventive healthcare for your patients in a lot of different categories. So that, especially in being in a rural area, that is a big credit to your leadership. So congratulations for that. If anybody has any questions specific for our case presentation, please you can go ahead and put it in the chat box or raise your hand. It looks like we have a couple. Dr. Hotz, if you want to go ahead and ask your question.
Yeah, just to make a comment, we have 30 different offices in our system, and this is the first office that I think are going to hit what we call the Triple Crown, 80% in each. And, one of the reasons is, the passion of the champion. Now, what Rita's not telling you is this weekend, she's going to go work for free, just volunteering to come in to catch up pap smears. And what we have found is that if you can bundle screening, so if you're coming in for a pap smear, make certain you send them a hemocall card. We have the breast and cervical program we get through the CDC, so we get the free screening for that. But it's the passion of the people. The other thing that is unique about this is we've had tremendous staff retention. There's not been a lot of turnover. Now, I know that's a challenge for a lot of health centers, especially with COVID. But what this serves as a great example of a myth bust, and the myth that both Rita and I talked about is the fact that, somehow African-American rural poor people, they don't care as much about cancer as, those rich inner city people, who've got a lot of money. The fact of the matter is, if you remove barriers, properly educate, and are trusted, you can perform at extremely high level. And this is a prime example. Now, part of it is the staff, part of it is being there a long period of time. Part of it also is, systems that you can put in. What you saw there is a fourth quarter push that Dr. Amin and Rita and others came up with. In the football game, we've got the fourth quarter where the game was won or lost. For those of us at the community health centers, that last quarter of the year, when you close out December 31st, those are your UDS numbers, and that's where you stand. And so what we've tried to do is to think about the fact that, you've got 3 months to close the deal. So if somebody comes in and they got a fit test January, that's due this year, and they're not coming back to January, you're not going to be up to date. So realizing that you got a limited time to get these things in is important. So, I think it's a real good example of the fact that, it can be done, but it does require focus, attention, and a very motivated staff like Dr. James.
Thank you, Dr. Hotz. I think Dr. Adiambo had another question. Lorianne?
Yes, thank you so much for the presentation. Congratulations on the numbers. Hopefully an 80% is an A, right? It's an A, so that's good, that's good. So my question is, there's a lot of passion and motivation there. But if you look at it, which evidence-based intervention would you say is being most effective in your clinic? Is it when you remind the patients, when you remind the provider to remind the patient? Is it provider assessment and feedback? Or is it when you remove the structural barriers, like you going on a Saturday? Which one of those, or the navigation, which one of those would you say is most impactful?
Well, I would just say, I really can't say one. I would say it would be the combination of all of those coming into play.
Okay. But if I was to tell you, you have to choose one.
I would just say the education to the patient when they're coming in to remind the patient. Yeah.
Okay. Thank you.
Thank you. Go ahead.
Robbie has a question. No, Robbie, Dr.
Robbie? Yep, Dr. Amin, Robbie.
Yep. Well, first of all, thank you so much, Rita. You're amazing. I know we've been trying to get you on for quite a while, especially because of how high performing you are. A quick note, I didn't break it down 50 to 75, but I think with the 50, you're going to hit over 80% or 80% rather, like right on, with the old guidelines. So that's a huge thing. To answer Lorianne's question, I have a question for you, Rita, in a second, but to answer Lorianne's question, just based on working with Rita, I think that one of the biggest motivators is the provider assessment and feedback, because although we can't work with her through the grant because she's too high performing, every time Dr. Hotz presents numbers at any medical meeting, she's always the one that emails me asking, hey, we're really close. What do we need to do? How can I help you help me? So, you know, I think the provider assessment and feedback has gone a long way there too. And, you know, every patient I've spoken to that has seen Rita always has good things to say. One thing I did want to ask Rita, if you can touch upon, is that same lines, you guys have been really strong in getting the 45 to 50-year-old, like with the age change, you're still a pretty high performing clinic. What have you found has changed? I know that's been a change for you as well, getting them to do the fit tests and things like that. Can you speak on that a little bit?
Yeah, I have actually, it might be kind of a little bit funny, but I know if anybody saw the Black Panther movie, and the guy in the movie, you know, he died of colon cancer. And he, you know, and I feel like if maybe the test would have started at 45, and a lot of people like for me to use something like that. And I'm like, hey, and you know, like Dr. Hott said, sometimes we may think that people in a certain area that they don't want the same things as someone else in an urban area. So if you provide it, you educate them, and they're willing. They just willing. It takes that time to educate them, to provide, you know, to provide them with the test, because they want the same thing other people want.
Thank you, and that's an excellent point. So there's another question. It just says Echo CRC screening, so it doesn't say a name, but whoever has a question, you can just go ahead and ask it. Whoever raised their hand.
Oh, I think that's Dr. Islam. Dr. Islam.
Yeah, I wanted to echo with Dr. James that the movie star, I believe he was at the Black Panther. The young guy.
Chad Boseman.
He was
Dr. Jones.
Very early age. It was sad, but that it happens. But I wanted to ask you, Dr. James, question. What makes you so motivated all the time? Keep going. Is there anything special that you have so that other can get that special tonic so that they can continue to keep up the higher rates?
I guess it's just a care for my community. And I've been in my profession for over 30 years, and I've had the pleasure of working with people in a rural area. And I've always felt that they deserve the same care that anyone else deserves. So it's just a passion of mine to deliver quality care in a low socioeconomic area, because I grew up in this area. I'm not a person that left the area. I came back, I came back home to service the people in my area. We have a lot of people come in, they get their student loans paid off, and we don't see them again. I've been here. I've always been in a rural area, and I like taking care of people in a rural area.
Thank you, and that's really, really nice to hear. Really refreshing, so thank you. Does anybody have any more questions for either Dr. James or Dr. Jones? If you have anything for, it looks like Dr. Jones has a question. Whitney?
I do. First of all, congratulations, Rita, just spectacular.
Thank you.
Can you talk a little bit about like that morning huddle before the day starts, when everybody's having their coffee and before it gets insane, and the importance of identifying, you know, what needs to be done for who, because that team spirit in the office that you bring is infectious. And maybe you can talk a little bit about that huddle and what that does for your day.
Well, I think you know, the staff, they are you know, they're invested in the community as well. And so, and then they're like me, they're chasing the Triple Crown as well. And you know, and we just work hard, because some patients, you know, they sent in a fit and it got denied. And so for those patients, what we do, we say, hey, when you finish your fit, just bring it in and we will package it and send it. So they work really, really hard. And I feel like, you know, they give 100% as well.
Very good. Are there any other questions for either of our presenters? We have time for probably about one more question before we go into conclusions. So if anybody has any last minute questions, this is your opportunity.
Let me make one last minute comment. One of the things that I think was really helpful is, you know, when you set a high bar, a goal that's inspirational. That's one of the reasons I had the University of Georgia there fourth quarter trying to win a national championship. So they set a goal to try to get to 80% and be the first one. And I thought Dr. Jones would love the Triple Crown coming from Kentucky. But one of the things that they were able to do, and Dr. Amin helped them, is to say that these are not infinite numbers. These are finite numbers. You saw there was 25, there was 23. So what it gave it gave the staff the understanding that, you know, a finite number of people to reach that goal, and it allowed them to kind of get tremendous focus. You know, let's just pick up a few here and there and we can be there. So I think, you know, that feedback and is as granular as you can give it, even to the number you have to do to get to 80% or 60, whatever your goal is, can be really helpful to let folks know that they can really accomplish the pretty amazing success.
Thank you, Dr. Hudson. Good point. So for the next session, first of all, thank you for both of our presenters. I mean, y'all did really, really excellent. I mean, this was a really inspirational session and a really educational session as well. So I'm going to hand it off to to Dr. Islam, and he's going to talk to you guys about CME. So Dr. Islam.
Well, thank you, everyone. And thank you, Dr. Desai, for leading us through the sessions and through the presentation and discussion. And I wanted to, special thanks to Dr. Jones and James for their wonderful presentation. It was really inspiring and wonderful presentations, very helpful. I wanted to let you know that all participants can claim credit, CME credit. If you want to receive the credit, please follow the link or use the code posted in the chat session. And also moving forward, we will need volunteer for our next presentation, case presentations. If anyone has a particular case would like to bring up, please email to us at au_CRC screening@augusta.edu. Our next session would be Wednesday, February 7th, 2024. And it's on Wednesday. We have session every other month, first month of the session, but we provide CME on the alternate month session. I wanted to thank you from the Eco Hub team to all of those who participated in this session. And we hope to see you next time. Thank you, everyone. Have a good day.
Thank you.
Thank you, everybody.
Thank you, everyone. Thank you.
Hub team can stay on.
Happy holidays.
Same to you. Good job.
As
Happy
well.
holidays.
Thanks.